Good afternoon, everybody. First of all, I would like to thank the organizers for giving us the opportunity to present this work here. I hope you still have some energy for this final presentation of the Thrombin Conference. In this presentation, I will focus on plasmin, platelets, and microthrombi, although the focus will be less on platelets, as the previous speaker already gave a very nice overview of the role of platelets and plasmin. So just to recapitulate, as I guess you have seen this now already a few times today, plasmin was initially seen as the enzyme responsible for fibrinolysis. Plasminogen can be activated into plasmin by tissue plasminogen activator, TPA, or urokinase. Plasmin formation is tightly controlled to ensure that plasminogen is only activated when needed. Regulation of TPA and UPA or urokinase is controlled by plasminogen activator inhibitor, or PI, of which PI1 is most relevant in plasma. The most important direct plasmin inhibitor is alpha-2 antiplasmin, and additional regulation occurs via TAFI, but I won't go into that during this presentation. So there's no doubt that the most important substrate for plasmin is fibrin, as you can see also in this figure here, but it's also true that plasmin has many other targets. As you can see here, plasmin and plasminogen have a diverse range of additional properties, such as cellular debris clearance, wound healing, resolution of inflammation, angiogenesis. And because of these additional properties, there are many potential roles and applications in which the plasminogen activation system can be targeted, as for example, a therapeutic strategy. So plasmin has many other substrates than only fibrin, and some are also hemostatic proteins, such as coagulation factor 5, 8, 10, fibrinogen, ADAMTS13, but also von Willebrand factor. And in this blot from the 80s, in this paper, they already showed that von Willebrand factor can be cleaved by plasmin. So here you can see the multimer size of von Willebrand factor as a control. And then in increasing incubation times with plasmin, you can see degradation of von Willebrand factor by plasmin. So plasmin cleaves von Willebrand factor, and that is my focus actually of this presentation. So before I go into results, I will quickly go over an introduction on von Willebrand factor, which most of you, I guess, already know. So von Willebrand factor circulates in plasma in a globular form. It has a varying number of monomers. Platelets bind to the unfolded A1 domain of von Willebrand factor via GP1B, and the A2 domain is cleaved by ADAMTS13. So upon vascular damage, the von Willebrand factor is released by activated endothelial cells via their ribosome antibodies and by platelet alpha granules. And the von Willebrand factor that is released is ultra large, which means that it's prothrombotic and the A1 domain is exposed, and this can then spontaneously bind platelets. Therefore, it's required that it's rapidly proteolyzed by ADAMTS13, and then you get less thrombotic multimers that circulate in the plasma that are still sufficient to support hemostasis. Upon vascular damage, you also have adhesion of von Willebrand factor to subendothelial collagen that is exposed, and that then allows platelet binding and subsequent platelet activation and aggregation. Well, how does plasmin fit into this story? Plasmin can, just as ADAMTS13, cleave von Willebrand factor. What you can see in this movie are endothelial cells in the background that are activated with histamine. These endothelial cells release von Willebrand factor, and von Willebrand factor is unfolded due to the shear, and it can bind platelets via the A1 domain. But then what you see here is the formation of the so-called beads on a string. We follow them for about 5 minutes to ensure that these strings are stably attached to the surface. And this is, of course, in the absence of ADAMTS13, otherwise these strings would be cleaved from the surface. At a certain moment, we add plasminogen and urokinase, and then you can see that these strings are cleaved directly from the surface of these activated endothelial cells. So here you can see that plasmin can cleave von Willebrand factor. We then showed that plasmin has little affinity for binding and cleaving of globular von Willebrand factor, and that you really need a shear, as just shown in the beads on a string assay, or denaturing agents to unfold and expose the A1 domain. What you can see in these results is that it's also a lysine-dependent binding. So in the top pictures, you can see what I just showed in the movie. So plasminogen and urokinase was added, and these strings are cleaved from the surface. But if you do this in the presence of a lysine analog, epsilon aminocaproic acid, these strings remain attached to the surface, so there's no cleavage of von Willebrand factor. On the right, you see a graph of an ELISA assay where von Willebrand factor was immobilized and an increased concentration of plasminogen was added. And then you see a dose-dependent binding of plasminogen to von Willebrand factor. But if you do this in the presence of the lysine analog, there's no binding. So what we show is that plasminogen can bind to a lysine-rich region, which is actually located in the A1 domain of von Willebrand factor. The group of James O'Donnell then looked for the cleavage site of plasmin in von Willebrand factor, and they found that the cleavage site is actually in a linker between the A1 and A2 domain. So they made a mutant where they mutated the lysine, which is present in this linker region, into an alanine, and they get two constructs, as you can see in the figure on the right. So they have the A1, A2 wild type construct and the A1, A2 mutated construct. And they incubate both constructs with plasmin for increased incubation times. And you can see that the wild type construct is degraded in time, while the mutated construct is not proteolyzed. So this actually confirmed that the cleavage site is in the linker between the A1 and the A2 domain. But what is then the physiological relevance of plasmin-mediated cleavage of von Willebrand factor? We looked into a disease where von Willebrand factor plays a major role, and that is TTP, thrombotic thrombocytopenic purpura. So as I already mentioned, when you have vascular injury, ultra-large von Willebrand factor is released by the endothelial cells, and this then is rapidly proteolyzed by ADAMTS13, here depicted as a scissor. However, patients with TTP have sporadic episodes with a deficiency in ADAMTS13 activity. So these patients cannot cleave or proteolyze from ultra-large von Willebrand factor. So what happens then is that you get spontaneous binding of platelets to the von Willebrand factor strings. You get microthrombi formation and occlusion of the microvasculature. So patients with TTP present with thrombocytopenia as a result of the platelet consumption in the microthrombi, hemolytic anemia, and a severe deficiency in ADAMTS13 activity. The symptoms are related to the organ ischemia caused by the microvascular platelet-rich thrombi. And in the acute phase, this may include neurological features ranging from a headache to a stroke or even a coma, abdominal, cardiac, renal disorders, skin and mucosal hemorrhages. Diagnosis is still challenging, so a lot of effort is currently ongoing to develop new point-of-care assays. And treatment is also still challenging, although a lot of progress has been made over the years. So patients are treated with plasma therapy, so plasma exchange to remove the autoantibodies and to replenish ADAMTS13 activity. Immunomodulation is started to, such as rituximab, to inhibit autoantibody formation. And more recently, drugs were developed to inhibit von Willebrand factor platelet interaction. And a few years ago, caplacizumab was approved for clinical use. And caplacizumab is a nanobody targeting the platelet binding site in the von Willebrand factor A1 domain. So it will actually bind to the A1 domain and it will prevent platelet binding to the ultra-large von Willebrand factor strings. And this improved the recovery of patients. So patients had a much faster recovery of platelet count and they suffered less from organ damage. Caplacizumab will actually only prevent the formation of new microthrombi, and it will not get rid of already existing microthrombi, and that's important for what I will tell later in this presentation. Currently also in clinical trials is recombinant ADAMTS13 for both congenital and now also acquired TTP. So how does plasmin fit into the story? Well, we hypothesized that the vascular damage that is occurring in TTP will increase plasmin activation. And then that this activated plasmin is able to cleave the von Willebrand factor-rich microthrombi, but that plasmin activity is controlled by Pi1 and alpha-2 antiplasmin. So we first looked into plasma of acute TTP patients and we measured plasmin alpha-2 antiplasmin complexes, which you can see on the left. These plasmin alpha-2 antiplasmin complexes are a measurement for increased in vivo plasma activity. And you can see that these complexes are elevated in acute TTP patients compared to patients in remission and compared to healthy controls. In addition, we also measured an increased PI1 activity, which you can see on the right, in acute TTP patients compared to patients in remission and healthy controls. So we see an increased plasmin activity, but it does not resolve TTP symptoms, as these are acute TTP patients suffering from the disease. But we also see increased PI1 levels. So plasmin is generated, but it's possibly toned down by several inhibitors. We then looked into mice with TTP to see if we have the same results there. We therefore used a mouse model for acquired TTP. We injected BLAC6 mice with antibodies against ADAMTS13. And when mice have inhibited ADAMTS13 or are completely deficient in ADAMTS13, they do not spontaneously develop TTP. They need an additional trigger to develop these severe TTP symptoms. And therefore, we inject them with recombinant von Willebrand factor, and then they, within a few minutes, they will develop TTP symptoms in a few minutes. These TTP symptoms are comparable to what we see in patients. So we see thrombocytopenia, which you can see in the left graph. The baseline platelet count is given, and then the platelet count after 24 hours, which is reduced. So thrombocytopenia occurs in these mice, and also hemolytic anemia shown in the right graph here by a decrease in hemoglobin, and also organ damage markers are elevated in these mice. When we then measure the plasmin alpha-2 antiplasmin complexes and the PI1 levels, we see the same results as in TTP patients. So on the left, you see an elevated plasmin alpha-2 antiplasmin complexes in mice with TTP compared to healthy mice. And on the right, you see increased PI1 levels in mice with TTP compared to the healthy mice. We then wondered, what would happen if we take away the main inhibitors? What happens if you take away alpha-2 antiplasmin and take away PI1? Then you actually get an amplified endogenous plasmin activation. Would this then help to recover from TTP? Well, the answer is yes. We used alpha-2 antiplasmin deficient mice and injected them with inhibitory antibodies against PI1, which you can see in the white dots. And in black, you see the control mice, which have normal plasmin activity and normal regulation of activation. You see the baseline platelet counts. Then after the trigger with recombinant von Willebrand factor, you see that the mice at 6 hours have all have thrombocytopenia. But then at 24 hours, the mice with enhanced plasmin activation in white are recovered. So they have elevated platelet counts. So with this, we show that TTP results in an increased plasmin activity. However, it's not enough to cleave all von Willebrand factor-rich microthrombi because there's too much control of endogenous plasmin activation by PI1 and alpha-2 antiplasmin. So the next question is, can we rescue mice and eventually also TTP patients by the administration of a thrombolytic agent? We first tested this in vitro by addition of streptokinase and plasminogen to the beads on a string assay, which I've shown before. So here you can see again stable beads on a string, platelet von Willebrand factor strings attached to the surface of endothelial cells. And when you add plasminogen and streptokinase, these strings are cleaved from the surface. We see the same in an agglutination assay. So there we mix platelets and von Willebrand factor. We add ristocetin to open up the A1 domain, allow platelet adhesion. You see an agglutinate formed. And then when the agglutinate is formed, we add plasminogen and streptokinase. And you can see that the activated plasminogen can completely degrade the von Willebrand factor platelet agglutinate. This was then also tested in vivo. Here you can see mice, the control mice on the left, which have a normal platelet count. Then the second group are mice injected with recombinant von Willebrand factor, so these have thrombocytopenia. And then the two groups on the right are both injected with streptokinase at different time points, but they all have almost a normal platelet count. So this shows that streptokinase can indeed rescue mice from TTP. However, injection of streptokinase would be too dangerous as it would allow systemic plasmin activation and hence results in an increased bleeding risk. Therefore, targeted thrombolysis would be a better approach. And this method was already elegantly shown by Wang and colleagues. And they developed a fusion protein where they attached a urokinase to a single chain FV which is targeted against the activated platelets, so activated TB3A. And what you can see in the graph on the left are the in vivo results, where they show that the red line is the targeted construct, so the targeted urokinase. It can lyse a thrombus, just as efficient as in black the commercial urokinase, whereas the non-targeted construct, so urokinase but not targeted to the activated platelets in blue, does not lyse the thrombus. More importantly, if you look on, to the graph on the right, they showed that the concentration of the targeted urokinase is much lower and does not induce bleeding. So the efficient dose, which does lyse a thrombus, does not induce bleeding, while the commercial urokinase, the efficient dose that lyse the thrombus, also results in bleeding. So this demonstrates that a targeted approach could reduce the needed thrombolysis, the thrombolytic concentration, while still being effective. So the group of Koen Maes from the UMC Utrecht in the Netherlands then developed microlyse. And microlyse is a urokinase attached to a nanobody which binds to von Willebrand factor. More specifically, it binds to the D' D3 region of von Willebrand factor. I already mentioned that plasminogen can bind to the unfolded A1 domain, and then if you have these two in close proximity, it can activate plasminogen into plasmin, and plasmin can then cleave von Willebrand factor in the linker between the A1 and A2 region. So they have performed a lot of nice in vitro experiments, which I won't go into detail here. What I would like to show here is that these are activated endothelial cells, so histamine activated endothelial cells that release von Willebrand factor. So in blue you see the nuclei of the endothelial cells. In red you see the platelets. And you can see platelets binding to the von Willebrand factor strings. And in the top picture in green you see the microlyse actually labeled in green. So microlyse binds to the von Willebrand factor strings on endothelial cells. And this is of course in a clean system without any plasminogen. But if you would add plasminogen, this microlyse will then degrade the von Willebrand factor strings. And also important that this does not interfere with platelet adhesion. This mechanism is unlike that of caplacizumab, because caplacizumab displaces the platelets from von Willebrand factor, and thereby it inhibits microthrombus buildup. However, it cannot degrade the ultra-large von Willebrand factor multimers. So you can see here caplacizumab labeled on these strings, and these strings, even in the presence of plasma deficient NMTS13, will remain on the surface. So in collaboration with the group of Koen Maes, we then tested microlyse in an in vivo model for TTP. And we used our mouse model, and we first took blood at baseline blood to measure baseline characteristics a week before the experiment was performed. We then induced TTP again with the trigger recombinant von Willebrand factor. Once the mice developed thrombocytopenia and other TTP symptoms, we started treatment with microlyse or one of the other compounds. And then at 24 hours, we measure the outcome parameters. And the main goal of any treatment in TTP is to reduce the attack duration and to reduce ischemic tissue damage. So on the left, you see the results of the platelet count. So you first see the baseline group. These are the baseline platelet counts. And then you see the group treated with saline, which nicely showed to have thrombocytopenia. And then in green, you see the group treated with microlyse. And you can see that microlyse actually attenuates thrombocytopenia, which suggests that microvascular obstructions are removed and that circulating microthrombi are degraded. On the right, in the right graph, you can also see the organ damage here depicted by the LDH activity. And you see a highly elevated LDH activity in saline-treated mice, while LDH activity is low in microlyse-treated mice. So LDH activity is normalized by microlyse, which indicates that tissue damage has been terminated. Then we also tested negative microlyse, which is the same concentration of urokinase, but not targeted to von Willebrand factor. And you can see that these mice suffer from thrombocytopenia as they have a low platelet count, and they also have organ damage. So this demonstrates that the targeting approach is really critical here. So without targeting, microlyse is not capable of restoring TTP in this model. And then you also see caplacizumab, the nanobody blocking platelet von Willebrand factor interaction. And you can see that these mice, the mice treated with caplacizumab, have thrombocytopenia and organ damage, which is not surprising because in this model we only give one single trigger to develop TTP. And as I already mentioned, caplacizumab is effective in preventing new microthrombi formation. So when you give it once microthrombi are formed, it is not able to degrade existing microthrombi. And we indeed show that if you give caplacizumab before the TTP trigger, it is effective in preventing TTP symptoms. And also importantly, microlyse is safe because we don't see a prolongation of bleeding time in mice that receive microlyse. While we did see a prolongation in bleeding time in mice receiving caplacizumab, which is logic, of course, if you completely block the hemostatic function of von Willebrand factor. So to summarize, plasmin cleaves von Willebrand factor-rich microthrombi. If you allow amplified endogenous plasmin levels, this can resolve TTP symptoms, but this is in vivo controlled by PI1 and alpha-2 antiplasmin. And a von Willebrand factor targeted thrombolytic agent has a good potential to treat TTP without inducing bleeding. So I would like to thank my colleagues at the Laboratory for Thrombosis Research at KU Leuven, KULAC in Kortrijk in Belgium. Of course, our collaborators, Koen Maas, Steven de Maat in Utrecht, and our other collaborators on this project. And I would like to thank you for your attention. And if there's any questions, I'm happy to answer them.